So thank you and welcome to the next in our series of webinars. Our webinar this evening is called Delivering Care Anywhere, Improving Health Outcomes Through Remote Patient Monitoring. And we'd like to welcome you all. I'm closing up the poll that was up there just a second ago. And let's go ahead to begin our webinar. It will be recorded, so it will be available to you and to a peer that you would like to share it with as well after the event finishes. So go ahead to the next slide. So this webinar is sponsored by the Office of Health Strategy and our Health Information Exchange, Connie, in the state of Connecticut, and it is put on by UConn Health. Next slide. And this is part of our continuing medical education and continuing pharmacy education series called Health Information Technology for Clinicians, How to Achieve Optimal Outcomes. I'm Tom Agresta, the Activity Director and Moderator, and I'm in the Department of Family Medicine and Center for Quantitative Medicine here at UConn Health. Next slide. We have a number of different topics that we have either copied or plan on copying in the future, including topics around medication safety and reconciliation, health data and analytics, telehealth, health information exchange, public health information, and patient-generated data. And this falls into that patient-generated data topic area. Next slide, please. Our learning objectives today is we're going to try to define remote patient monitoring, discuss its benefits, discuss how the utilized data can improve chronic conditions and management of health outcomes, describe how health information technology can be used to collect the data, analyze it, and present it to clinicians for remote patient monitoring, to identify the challenges to the best practices to implementing and applying RPM, as we're going to refer to it a lot tonight, we'll call it RPM, and describe how some Connecticut providers are beginning to use remote patient monitoring to better deal with underserved populations. Next slide, please. A little bit of housekeeping. During the presentation, the participants' lines are muted. We will have a question and answer session at the end, and we'll be capturing the question and answer information in a Q&A area on the webinar. You can put your questions into that Q&A section on the WebEx, and you will be able to answer your questions at the end. If we do not get to all the questions, which sometimes happens, we will try to put together an FAQ sheet and share that with information afterwards. And at the end of the presentation, we'll give you some information about how to access continuing medical education and continuing pharmacy education credits. Next slide, please. Tonight's presenters, I'm pleased to introduce. Lyle Berkowitz is a general internist, a clinical associate professor of medicine at the Feinberg School of Medicine at Northwestern. And he's the founding director of the Zolozzi, and I'm going to have Lyle correct me on that, I'm sure, Healthcare Innovation Program at Northwestern Medicine. And Lyle and I have known each other for a number of years. He's also an entrepreneur and involved in a number of different projects, helping set up health IT demonstration projects in the past, and also sort of a thought leader in how to utilize technology effectively in clinical care. Richard Albrecht, I've also known for a number of years. He's the executive director of telehealth for Community Health Network in Connecticut. Rich has had experience working in remote patient monitoring activities in the past with Philips. He's also been on the executive leadership of ProHealth Physicians in Connecticut in the past, and he's going to share some experiences that the community health network has been having with some of the community health centers in the last several months. Let's go on to the next slide, please. So I'm going to hand it over now to Lyle, who will bring us through the next, walk us through the next series of slides.
Okay, thanks, Tom, for having me. And looking forward to talking a bit about remote patient monitoring with everybody. I'm sure some of you have a good sense, some of you are still learning. So we're going to start with quickly going through what do we mean when we're talking about RPM, remote patient monitoring, and more specifically, the CMS definitions. Because the bigger picture, of course, remote patient monitoring could mean a lot of things. In some way, you're monitoring your patients who are away from your office. And for the first time in the past couple of years, the CMS has started paying for this in a formal way. And some private payers additionally are doing this. And of course, it's always had some value in a value-based scenario. But let's look at the CMS requirements. One, the device must meet FDA definition of a medical device. These are things, of course, like blood pressure cuffs, pulse oximeter, glucometer, etc. They don't need to be FDA cleared, but they do need to be checking some type of physiological measurement. The information does need to be uploaded. It's not simply self-reporting. This does cover patients with acute and chronic conditions where you do have something to monitor. Again, the most obvious ones being things like blood pressure, diabetes, hypertension, diabetes, and CHF. The monitoring, to get paid, you must monitor at least 16 days out of a 30-day period. There must be a piece of data from at least 16 days. Does not mean you're talking to them every day, but that your system is monitoring and that the qualified healthcare professional time does require some interactive communication. This can be anything from a provider to another qualified healthcare professional on the provider's team. So next slide, we'll go to a more holistic discussion of what and why and how we're doing this. On the left side, you can see a variety of devices that you might check, from EKG monitoring to blood pressure to glucose check. And what we're, of course, doing are looking for trends, changes, alert values, because the end goal is, one, how can we use this data to better educate? Two, how can we make sure we have an early warning system, some alert of some sort, if a patient is doing poorly? And three, this gives us an opportunity to follow up with the patient in a consistent experience. As a primary care doctor for 20 plus years, I know what it is to see a patient once or twice a year and recognize that, beyond those visits in the office, I really have very little communication with them, and certainly not regular monitoring throughout a month. And this is the way where we can identify trends and issues early, and certainly find someone, as we say, like an early warning system, understand if and when they need to come back sooner, if and when our nurses can educate them and or escalate as needed. So in the next slide, we'll sort of look at an example of what data might look like throughout this system. Imagine starting on the left side, a patient using a device that can go into a cloud where your staff can monitor. This can be your staff. There are companies where you can outsource this to external staff, and that data is usually integrated in some way with the EMR, and or the staff can communicate via the EMR to notify a primary care doctor if and when's needed, and whether that means you need a primary care doctor or other physician to call the patient or simply to see them. And all this can also be integrated within a health information exchange to get even further data. But remember, patient-generated health data, PGHD, a term we may hear more in the future with HIEs, can then be used for a variety of data analysis. So in the next slide, this might be what a staff person would look at. You can imagine a nurse being able to review a patient's profile, looking for where are their red points, where are their numbers out of the ordinary. These can be simple trends that allow the nurse to have a better discussion with the patient. It looks like at 9 a.m. You had a peak in your glucose. What was going on? What were you eating, etc. And have more thoughtful discussions. There can also, of course, be alerts and triggers that would more immediately notify the nurse of a glucose particularly high or low. We have, of course, had anecdotes over the years on both sides of the story, and particularly important, obviously, in the case of a very low glucose, a new onset of AFib, a blood pressure that was rising abnormally. And so these are the type of things that a nurse or staff can use. We all worry about as doctors, oh my God, we're going to be overwhelmed with all this data. That's not how these are usually set up. You usually do have a staff person who's been trained to look for trends, evaluate, has a limited number of patients, and a care coordination type of scenario. I know some of the external vendors that I've talked to, they'll have one nurse assigned to 200, 250 patients, and that's their responsibility every day to be able to review, perhaps 10 of those patients, so that they can get through all of them, contact them, discuss their issues, as well as be alert for major problems. But as a doctor, the main thing that we'll have is knowing if a patient's coming in for a specific reason, we'll be able to see a summary or an alert. Let's go to the next slide. Yeah, the big picture here, of course, is that we have a limited number of physicians to take care of patients. So we do have to think more and more about team-based care. And remote patient monitoring is both a technology, but also a compensation mechanism that allows us to expand what a team can take care of, while making sure the physician can focus on the highest order, most complex patient. You can see here, though, there's layers to the team. So patients who are doing well, they have minimal problems, they may be monitored by someone on your team at a level of a medical assistant. As it gets more complex or there are more issues, you'll bring in nurses, PharmD, pharmacists, social workers, etc., who can manage those patients who are medium complexity. But the idea is that as a team, you can take care of more patients, but as a physician, you may see less patients, but you're seeing the ones who really need to see you. And that's always been an important part of what I think is a solution to our healthcare system. I'll often say we don't have a shortage of physicians, particularly primary care physicians, as much as we have a shortage of using them efficiently. And this now allows us to say, hey, we can actually monitor more closely. We can have it all. We can take care of patients better. We can make money doing it. We can decrease total healthcare spend, and we can let doctors focus on the patients that really need us the most, rather than filling up the offices with what would be green patients and red patients having to go to the emergency room or not get seen. So this is an important part of the holistic vision we have that we talk about in terms of population health, which we often talk about and can only happen in a value-based world. But with the new codes, we have the ability, even in a fee-for-service world, to have a way to have financial compensation and incentives that allow us to do the right thing. Next slide. We are focusing on RPM, but we also want to bring up, there are also something called CCM codes, which are for patients who have multiple chronic disease. There's acknowledgement that those might be more intense, and there might be more money there. And then coming in 2022, maybe another election in the future, remote therapeutic monitoring, which is different than either the RPM or CCM codes. remote therapeutic monitoring are about therapies, particularly around musculoskeletal, things like virtual physical therapy and respiratory therapies that can be done remotely, maybe even autonomously, and there are financing mechanisms for them. Just wanted to touch on the fact that there are increasing amounts of programs coming out to be aware of. And again, something that I think starts to align doing the right thing with particularly with primary care or office-based outpatient physicians. Next slide. In terms of billing, there are a variety of codes here. The 99453, of course, setting things up, and 454, getting your the device supply, and then the additional ones are a variety of collection, interpretation, and interaction with the patient and or caregiver. The usual expectation is that may take about 20 minutes of time from a nurse or other part of your team, and that can result, when you bundle it all up, into perhaps $100+ a month per physician, per patient, and that can even go further if they do expend another 20 minutes, 40 minutes, or up to 60 minutes a month. There are additional payments that can be made. Next slide. There are a lot of companies, of course, in the digital health, telehealth, remote monitoring space. We want to have a slide here that represented everything from the actual monitoring devices to services that support it. We're not going to go through each of these, but there are a variety of different opportunities to do things yourself completely, which would be involve everything from getting the device to enrolling patients to monitoring, et cetera, to outsourcing various parts of this. It might just be the onboarding and devices. It might include full monitoring, so that the only thing you as a physician's office may have to deal with is giving and sharing data to allow a partner to identify which of your patients might be eligible, and being aware and able to take care of patients who hit a threshold and need to come in more quickly because of perhaps an alert that was found. Next slide. Some of the challenges to think about, of course, on the patient side are going to be the patient's skill and ability to use different devices. Again, we've gotten easier and easier and seen a lot of companies help with onboarding. So literally is a wireless device that has everything hooked up. So all they may have to do is plug it into the wall. They don't have to connect it to their Wi-Fi or Bluetooth or anything else special. But that will always be an issue, and this is also where family may be able to help. On the other side, on the physician side, of course, is understanding who's going to get this information. What are the triggers that are important? Can you personalize it for every particular patient? Mrs. Smith, you may want to know if her heart rate goes over 130, but Mr. Jones, it might be any heart rate over 100. And so understanding your workflow, and of course, financially making sure that there is a ROI for the time you have to put in. And in between, of course, is ensuring both data security as well as validity, making sure there's not an overwhelming amount of data volume or flow that happens, and particularly all of this if working with a third party. The next slide. Just wanted to go over some of the cost benefit. If you're in a fee-for-service environment, or what the ROI might be, this can represent, of course, new payment for something you may have done lightly before, but doing more intently now. It can also ideally free up physician time from low complexity care to more high complexity care, or in some cases from care that they were not being reimbursed for at all to care that they can be reimbursed for. Again, doing the right thing, but getting compensated for it. While in a value-based world, of course, you have the ability with remote patient monitoring to improve compliance, early detection, resulting in lower risk of going to the ER, admissions, readmissions, improving quality scores. The nurses can talk to the patients not just about what the monitor is showing, but also the importance of compliance with their medication, as well as compliance with care gaps or other things that they may need. And I know we've seen this at a general level, but also personally, that we have patient satisfaction often goes up. You'd think, oh, how would this happen? This patient's talking to some stranger. They get very close to these nurses very quickly. Usually you and or your partner is going to have, of course, a nurse assigned to the patient. So that nurse or other part of your team is the one who is consistently communicating with that patient. And they look at that as a part of the team. So it's part of Dr. Berkowitz's team. They know that nurse has a direct line into my office and me if needed, and they feel more taken care of. The next slide is we're going to end with a poll. And of course, if you have noticed on the right side, there's a Q&A section. You can put in any questions that we have. We will have time for that at the end. But we wanted to finish this section with a poll of what do you perceive as the biggest benefit of RPM for patients and or providers? This, of course, may be on your viewpoint. Is it quality and aspect of decreasing ER visits, hospital admissions? Is it about medication compliance, improving care gap closure, or provider reimbursement? What do you think is going to be particularly the benefit that gets your practice saying, hey, we really need to do this? I don't think there's comments there. You can put any comments in chat if you want or in Q&A, but I'm going to pass it over to Tom to help us set up that poll, because it looks like the other poll may still be up. And we'll
Yeah,
be able
I'm gonna show the poll results from the initial one. So I'm going to show you that in the initial poll, it should now be kind of showing for folks.
There it is.
There on the right, it should show, do you currently, this is when people were signing on. So it's the folks that signed on a little bit into the beginning won't have seen this. But basically, do you currently include remote patient monitoring? And only one out of the 11 or so who answered this is currently doing it. So this is a newer thing for folks, and many folks didn't actually answer that one. So I'm going to kind of hide that poll results, and now I will open up the second poll, and we'll leave this poll open for a little bit of time, and then after about 5 minutes, the poll will close. But go ahead and answer this. And then I will go ahead and have us switch over to Rich Albrecht, and Rich can kind of start with his presentation. And once he's finished with his presentation, we'll show you the poll results for this.
Thank you, Tom. And it's a pleasure to be here, and a privilege to follow Lyle's great high-level overview of remote patient monitoring. As Tom mentioned, I work for a group of federally qualified health centers here in Connecticut, and have had the opportunity over the last year and a half to work with a couple of our centers in the development of a remote patient monitoring program or programs, specifically focused on our patient populations. And so if you're familiar with community health centers, you understand that this is all about dealing with patients who have a lot of challenges, specifically around income and poverty level, ethnicity, language, digital literacy, access to technology. These are all barriers that get in the way of care. And the application of telehealth, and specifically tonight talking about remote patient monitoring, is proving to be an effective solution for some of those challenges. In the community health center setting, primary care is largely about managing patients with chronic conditions, and to a greater extent than in other settings, perhaps, we see 70% of our patients are either hypertensive or diabetic, and a very large percent of those are often uncontrolled. So this creates an opportunity for application of technology that might actually give us more information that could be actionable and helpful to manage that care in between their visits, even if they're having today some virtual visits in addition to seeing their provider in person. having some additional information between those visits can be very helpful. And that's what we're going to talk about tonight, and how we got to where we are. And I will say this as I begin, we are in very early stages of doing this because there's not a whole lot of remote patient monitoring being done today in the safety net setting of community health centers. Next slide, please. At a high level, our process, and this is a visual of it, extends from having that patient take a reading with a biometric device, whether in this case a blood pressure monitor, it could be a glucometer, or any number of other devices, and getting that data into a form that it's meaningful and into the patient record. So there's three things that go into this. One is solving for some of those disparities in access we talked about on the last slide. Another is not overwhelming the clinical team. We have to make sure that we're not just generating tons of data. It's got to be down to actionable information. And lastly, you have to be thoughtful in this setting to create a program that is sustainable. Because for community health centers and rural health centers, there's currently no reimbursement for remote patient monitoring. Although CMS has established reimbursement, generally, community health centers, FQHCs, rural health centers are currently excluded. So we have to be thoughtful in how we create a program that is sufficient to do what we need to do, yet still be sustainable. Next slide. There we go. So for most patients in the community health center, keeping things simple is critical to our success. So we spent a lot of time on this particular piece, looking for systems and methodologies to make this as easy as possible for our patients. So here's a visual of one of our units, patient taking a SpO2 reading. And in this particular case, all the patient is doing is taking that reading, and that little device you see in the background is a hub that plugs right into an electrical outlet, and the device on the patient's finger is communicating via Bluetooth to that hub, and that hub is actually sending that information to the health center. But all the patient had to do is, when they first set up this system, plug that hub into their outlet, and then forget about that piece, and then just remember to take their reading each and every day. And simplicity is critical, because simplicity makes it easy for these patients to stay engaged, and staying engaged for the long term is what's critical to making the positive behavioral changes that you're trying to get in a patient where you're using RPM in a primary care setting to help manage multiple chronic conditions. Next slide, please. So the patient sees their device and they see that hub plugged into the wall, but they don't see all the other things that are going on in the background. We look for systems from a technology standpoint that do just what that last slide showed, keep it extraordinarily simple for the patient, yet are taking advantage of all the technology that's out there in terms of broadband accessibility and being able to get the information from the device to the patient record in the easiest way possible. But it's typically going to involve a couple of different steps. The patient doesn't need to know anything about that. All we want them to do is to take their readings. Next slide, please. So in one of our centers, we're actually using devices that are directly enabled cellularly. So there's no Bluetooth hub required. In this case, the patient is just taking their blood pressure reading in their home, and that device is sending the information directly to a cloud-based portal. And so the difference between this system and a system that uses a hub is simply that this device has the communication chip already embedded. For an FQHC, where reimbursement is an issue, we're cognizant of the fact that this system may be a little bit more expensive. While it's one step easier for the patient, these devices can be more costly. So we have to be cautious about that. But we have in my particular setting, I've got a center that's using devices that are directly wirelessly enabled like this, and I have a system that is employing a wireless hub and Bluetooth devices. Next slide, please. And so in either case, the data from those devices is flowing to a cloud-based RPM data dashboard. And one of the things that we talked about when we were starting these programs is that we did not want to overwhelm our clinicians with a lot of benign data that was within clinical range. But what we wanted was and what we needed was actionable information. And so the use of a data dashboard enables us to quickly look through a list of patients who have devices using a color-coded system and with enabled alerts for patients who are significantly out of range. We can quickly and easily, using part of the clinical team, we can identify those patients who need attention, address that situation specifically for those patients, and report on whatever activity needs to be put into the patient record. So next slide, please. One of the advantages of a portal dashboard is it typically has useful data visualization capabilities. So here's another view of one of the dashboards we created for one of our centers. That this one is particularly useful when we're managing patients with multiple devices and a variety of clinical conditions. So the ability to visualize that data as you drill down into the patient becomes very important. And this is not typically the capability that we'll find in a medical record system. So having that interim step of the patient data portal is very, very helpful. Next slide, please. And you can then take that individual clinical condition and drill down into specific data for specific periods of time and generate reports, and take pieces of information like this and post it into the patient record. These things are these types of visualizations are really, really helpful and lend themselves to be particularly useful in a situation where you're going to be perhaps referring a patient to a specialist. And wouldn't it be wonderful if a specialist, through the use of a health information exchange, could access this same visual of a patient that you're referring to him or her? And so here's where the aggregation of data into actionable information becomes very, very important and very useful. Next slide, please. So some lessons learned, specifically for us in our setting. Probably the most important is to keep it simple for the patient. Keeping the technology as easy for the patient to use. What we found is that less is more. Not having the need for a patient to download an app or have connectivity or broadband. We take care of all that. And providing a simple technology and then providing thorough training on it, because even though it could be as simple as simply turning on the device and taking your reading, we take nothing for granted. So every patient that we put on remote patient monitoring goes through a training program. They get materials that they take home with them, and we have a little saying that's called "Strive for 5." And what we mean by that is we want the patients over the next 5 days after we've given them a device to demonstrate each consecutive day that they can take a reading and send that reading successfully to us. And then lastly, we proactively support those patients. We reach out to those patients periodically throughout their time. We do not depend specifically on that patient. Even though that patient may be sending in readings to us that are right within their clinical range, we do reach out periodically and check in with them and make sure that everything's working along very positively. Next slide, please. For our clinical teams, a couple of things really have stood out so far. And I will tell you that we are about a year into a program with one of our centers, and we're about 4 or 5 months into a program for our second center. So as I mentioned right at the outset, we're still early stage in remote patient monitoring, but it became very evident that one of the most important things we needed to do right up front is communicate. We have to explain the value of why we're adding one more thing, one more stream of information, if you will, for a PCP team to now manage. And we need to communicate the value of this and really answer all the questions up front, and then start to demonstrate the outcome data, which really will convince, we have found, even the most initially reluctant teams, that this is something good for our patients. So getting everyone rowing in the same direction is critical. The other thing that has become very, very important to us is designing effective clinical workflows. These are essential, and they help us make sure that, as Dr. Berkowitz pointed out earlier, that the right work is being done at the right time by the right person on the clinical team. And we utilized an AMA resource published in 2018. This is their digital health implementation playbook, and I highly recommend it. It's very thorough, what I'd call blueprint for any practice looking to implement remote patient monitoring. Next slide. So these are some early observations from our first center a few weeks after they launched RPM. And it was some of these anecdotes that were very helpful in communicating the value of why we were going to begin offering RPM to some of our patients. In the initial incident here, we have a patient who we were able to intervene early and go ahead and change medications. And that was very, very helpful for that particular patient. In the second, we have a situation where we were able to, again, based on the actionable information, intervene and refer a patient to the appropriate care. And lastly, we started to see patients who, having a device, start to trend to normal readings. And this was very, very rewarding. Patients who had previously, based on the information that we had, and in some cases, we had patients who had a device and were self-reporting their information. Now with an automated system, we were able to see far better results. And some of these patients now have graduated from this program, patients that have demonstrated consistently meeting their, in this case, blood pressure target range goals, And in these cases, we allow the patients to keep their monitors and self-manage themselves, and we continue to provide them periodic support calls between their regular office visits. And I will say that the programs in both cases have been successful, especially in the case of the center that's been doing this for about a year. We've had fewer than 10% of the patients terminate due to non-compliance. So, so far, so good. We're very pleased with the results. And in the months ahead, we're going to begin aggregating a lot of the data that we're really now starting to collect. And next slide, please. So we have one more poll.
And Rich, before you talk through that poll, I'm going to share the results of the prior poll. How's that?
Oh, great.
Okay. So the prior poll, it was, what do you perceive as the biggest benefit of remote patient monitoring for patients and providers? And as you can see, of the 60% of participants who answered, 23% perceived it to be decreased ER or hospital admissions, 14% better patient medication compliance, 20% increase in care gap closure, and just one person kind of said improved provider reimbursement. So I think what the takeaway point there is that people want to do this because they believe it's going to improve patient care, and it's less about the money and more about the improvement in patient outcomes. So I will go ahead and now open up the next poll, and people can answer that. Well, Rich, will you read them off?
Sure. So in this poll, we'd like to ask the question, how the collection of RPM data could improve patient-centered care in your practice? Increase connection between the provider team and the patient, monitor trends in the patient's health, proactively address any concerns before they develop into more serious conditions and problems, or determine medication effects and modify if needed. I will tell you, and not to sway the results of the survey, in our experience, we're seeing all of these. So it'll be interesting to see the results of this poll. And now I'll turn it over to Tom.
So while folks are answering that, we're going to go to the next slide, and we're going to share a little bit of current data about an experience that was published very recently from New York Presbyterian Hospital about RPM use in COVID. And just to show you what a mature organization that's utilizing remote patient monitoring can do, and how they can rapidly shift to using this technology in the pandemic and under substantial duress, how they can actually kind of achieve something pretty significant just by leveraging the work that they've already done, like both Lyle and Rich had kind of laid out. When you've set up the systems and made them work, here's what you can kind of do with them very quickly and effectively. So they had existing programs in remote patient monitoring for heart failure, which is a very common area where remote patient monitoring will be used. And often it's the first place that a healthcare organization will do it is out of a heart failure unit. And they also had a ambulatory set up for remote patient monitoring to kind of deal with hypertension, because they had a lot of patients that they were trying to lower their blood pressures to goal. And so they took that existing remote patient monitoring, they were able to shift with the staff and the team and the approach and add oxygen saturation and O2 concentrators to folks that are having problems with COVID when they were having respiratory difficulty. So what they did was they took that program they shifted it, a number of the people that were involved, the device companies, the infrastructure, the monitoring, and they modified it quite a bit. And they applied it pretty quickly to 2,000 patients who were discharged from the emergency room, and 3,600 patients who were either out of the hospital already or were at risk ambulatory patients, all of whom were positive for COVID and had some challenges with oxygen saturation at the initiation of the experience. They were able to leverage, like basically taking people that we mentioned before and have their physicians and their PAs and their nurse practitioners working at the top of their license, and they actually had medical students, some PAs and some that were from ambulatory sites that were kind of closed down, doing daily calls, but monitoring their patients' symptoms. That's what they were monitoring with the daily calls, and their temperatures, but they were having their O2 saturations automatically sent in for remote patient monitoring. They established some protocols to escalate it to a physician or send folks directly into the ED. And out of those 4,600 or 5,600 patients, they were able to actually, this is kind of an amazing thing, they were able to actually have only 22 sent into the hospital to the ED, or 33 patients get readmitted, which if you were participating in any way, shape, or form with COVID in an ambulatory setting, you would know that that was an amazing amount reduction in people actually going to those settings that would normally go if you didn't have the ability to actually monitor not just their symptoms, but also their actual oxygen saturation. They were also able to actually get patients sent home, not just with an O2 monitor, but also a concentrator if their oxygen saturation was below 92%. If you can go to the next slide. They did that by doing some of the same things that you kind of heard mentioned before. They actually provided care coordination across the different kinds of providers. They actually set up their primary care clinicians, their specialists, and their ED. They communicated and worked with them all up front to make sure that everyone was on the same page and they all were playing on the same playbook, so they understood that process. They actually found that device management was very important. The keep it simple approach, as Rich mentioned before, was critical. So they made sure that they had the same way of managing the handing out of devices and the handing back. Now, unlike what Rich noted with the individuals being able to keep for their chronic conditions, keep their blood pressure cuffs, this was a situation where they wanted to recover those O2 sat monitors to hand them on to the next group of individuals after that 2-week time frame had occurred. So they wanted to be able to recycle them, clean them, and get them back out for reuse. And obviously they discovered that digital literacy, the ability of the patients to understand what was being given to them and educating them about how to use the tools effectively, and access to Wi-Fi. And I don't think the tools they used were as seamless or as easy as what Rich noted in terms of connecting to Wi-Fi and getting the data sent back in, but they found those things were very critical and important as well. So those are some lessons that were learned and reported on recently. And there are several other pieces of literature out there talking about COVID and remote patient monitoring. And I actually think that the pandemic substantially increased the utilization of remote patient monitoring tools for clinicians, as most of us did switch to telehealth. Even those of us who didn't have a substantial remote patient monitoring tool in place did actually start to actually have our patients record a lot more things, try to get it into the electronic health record, et cetera, as well. So I think we're shifting towards this technology use in a much more substantive way. So I'm going to now open up the poll and show the poll results from before. And it looks to me like what ways can RPM collection of data improve patient-centered care? The vast majority of folks that answered actually suggested that proactively addressing concerns before they become health problems was the most important way that it could help. The next area was increasing connection between the provider and the patient. And then obviously medication effects and adherence. I can tell you that in our own practice, we do some, have in the past had pharmacists actually work directly with our patients, do monitor continuous glucose monitoring and other things, and really have found that their ability then to monitor and adjust medications is of great value in our own patient monitoring process. So if we go to the next slide, we're going to now open this up for questions. And we've got a good amount of time set up for questions. I am going to open up a new poll while the questions are going on. And that's going to be very simple. What type of solutions might you implement in your practice? And then I'm going to go ahead and start passing on. There's at least one question in the Q&A. Please go ahead and add questions to the Q&A section, which should be found at the lower right-hand corner of your, WebEx environment, or put things in the chat, and we'll start asking our participants. This first question actually looks like it's probably for you, Rich, and that is, did you text patients? Did you use any texting for the patients that you were trying to communicate with?
We have not deployed a robust texting system to date, although we are in the system that we are using, that we've been have deployed the longest. We are considering expansion of communication into a bi-directional texting system. We see there's great value and efficiency in doing that, but up till now, we've just simply been utilizing telephonic, or in some cases, video.
Okay.
I can add in some more thoughts. I've actually gotten involved in that area a bit. So there's texting, right, just off of your phone, but that's not particularly HIPAA compliant. Not completely legal if patients, say that that's how they want to be communicated with, but most people these days are using either secure messaging through their EMR portal, something that involves the patient having to put a username and password in. So depending on your EMR, most of them have some type of way to communicate via email securely, but that's not really real time. So there is this concept of secure texting, in which you or your nurse can use a system on your side, send what is something that would go to someone's mobile phone like a text. Usually it winds up being a link that they then can click and go into a secure site where they can communicate it essentially real time in a secure manner. This can be done via chatbots, so it's fairly automated. Hey, I've noticed you haven't checked your blood pressure in the past 2 days. Can you make sure to do it? And or it could be something that is triggered from an abnormal vital sign, and it can often hand off and or can be directly related to a live person. So the nurse could securely text the patient, send them additional information, ask them to clarify, ask them, what's going on with their blood pressure, their glucose, etc. Do they have time to talk, etc. So I think it's going to be a really important tool in the war chest, so to speak, on keeping track of and how to communicate with patients.
Excellent responses. And then there was a question that came in through chat regarding monitoring protocols and then rapid response mechanisms that might need to occur So for example, if someone has a substantially lowered oxygen saturation that went down in a hurry, or a blood pressure that was, way out of norm, or a blood sugar that was way out of norm, how do you need to both educate your patients and your providers around how to handle those things, and what might be the implications for managing risk in those circumstances?
So I can start that. This is a topic that came up early on in both of our programs. First off, the establishment of a solid clinical communication protocol is critical to the success, right? And so in each system, we have alerts set, and they're customized per patient based on that patient's condition, and based on the severity um, of the information, the data that's being generated. We'll either get an email or a text alert to someone on the clinical team. Um, with and so that's how we address that, and we have protocols of response based on the alerts. So with respect to the issue of risk, that's an important topic, and we make sure, because so our remote patient monitoring comes out of the really originated as a post-hospital discharge program for very, very sick patients who needed a lot of attention and 24/7 monitoring. What we're seeing, and you alluded to it, Tom, as a result of the pandemic, the use of remote patient monitoring is really expanding and into primary care, and we're classic examples of this. But the program that we have is not that 24/7 monitoring where you have someone sitting at a computer looking at data each and every minute. So we make sure that we inform the patients right up front that we are helping them with this device to manage their conditions, and we instruct them if they have a certain type of reading based on their clinical condition, meets a certain threshold of what they need to do if it's after hours or on weekends. So it's a different type of remote patient monitoring than you would find in a hospital setting. And it's important to have that information in the patient consent, and also to communicate that broadly.
Yeah, I'll add, because I've talked to some folks who are doing this. It's very much emphasized. This is not acute 24/7 ICU monitoring. This is, long-term monitoring. With that said, if there is something that's clearly outside the range, as Richard said, you want to have a protocol in place. Usually that might involve a nurse contacting the patient, clarifying what's going on. Maybe they were using the machine wrong, there was an error. But if it's right, it's then some triage to either connect you to your primary care doctor to do some immediate triage and or get an appointment set up. There are capabilities in extreme circumstances, to call 911, etc. But that's usually not what these are for. And it's not that different than if a patient calls your office and says, "Hey, my home blood pressure reading is saying it's 180 over 120 and I have a headache, what to do?" We are professionals, we handle these things, and we deal with them as they come up. But this could be where some autonomous chatbot secure messaging might come into effect. For example, I'd like a system that if a patient did check their glucose at 2 in the morning, or blood pressure, and there was a major problem, that they'd get a message saying, "Hey, this is really out of range. You should talk to someone, do something, consider doing something," to at least alert them. But again, most patients sort of know that as well. Again, if your glucose is 20, you're probably not able to check your glucose at home, or if you are doing it for someone else and it's very low, you're probably calling 911. So these things do happen, but the RPM is not set up to be a 24/7 continuous monitor.
All right, so here's the last question, and then there's a few others that we will, I promise, put out a response to when we do the follow-up emails to folks. What do you think that you'll be able to use the cost savings achieved from RPM to justify more FTEs to follow up, RPM care? In other words, does this have enough of a return, either from cost savings or from reimbursement, that it should expand the team and make it more effective going forward?
Yeah. I'll start on the fee-for-service side. If you can enroll 50 patients, that can result in upwards of $75,000 a year. 100 patients, twice that, and that can certainly pay for staffing. And a lot of these outsourced companies will take this over and do it in a no-loss scenario where they're doing the work. You are sharing in the gains and not taking any of the risk. On the cost saving side, that's a bigger population health answer, and probably the answer is going to be absolutely if you do it for the right patients. Whereas in the fee-for-service side, you're probably going to be open to doing to as many patients as possible. On the value-based side, you're going to probably limit to, let's make sure we're doing to the patients who are truly at high risk, and there's probably a little gray area in between those two. And Richard, curious what your experience has been.
Yeah, so in our unique, I'll call it somewhat unique anyway, environment of not having reimbursement, we're leaning more toward the value-based side of the equation, where we're looking for those patients who really need it most. And we've got to be cognizant of the fact that there are some costs associated with this. Our ultimate goal, though, to the question is that we hope that the data that we generate in terms of early intervention will justify some level of reimbursement to minimally cover our costs associated with this. We're not looking to make a lot of money on this in an FQHC environment. We're looking to help keep our patients as healthy as possible.
All right, excellent responses. Let's go to our next slide. And it is to thank our presenters. Oh, that's right. I'm supposed to show the poll results, right? While we're going ahead and showing the poll results, which basically say that properly educating staff is the solution that may be most appropriate to do, as well as integrating the current EHR.
Yes.
And I think those are very real things. And I really would like to thank our presenters for their time and their interesting perspectives and their experience in this. For those of you who are seeking continuing medical education or continuing pharmacy education, you will receive an individual email with the feedback that you need to do and the follow-up that you need to do within a short period of time, and you have 2 weeks to complete evaluations, etc. And as always, have a good week, and thank you all for your participation.
Thank you.
Thanks, Tom.